that I'm a recovering clinical engineer. We're going to move to the questions and answers, and I'll just share a few ideas for us to prime the pump. Our work is, it crosses so many professional areas. I call it massively cross-disciplinary. It's not just multiply disciplinary, it's massively cross-disciplinary. We focus on the safety side. We bias towards saving lives and providing these kinds of support and services across the globe. Next slide. We have a lot of skills that we need to develop. Fred Hosea, a couple of years ago in the WHO book on human resources, identified this clinical systems engineer opportunity and requirement. And this is something I've been speaking to almost for 15 years. And Derek talked about very nicely. Next slide. There are a whole bunch of new skills and tools like the systems lifecycle support for information systems, very different than what we do with devices. And it also collides with business management. These are new languages and methodologies. Next slide. We have skills that we need to develop in our own community: software and systems of systems engineering, analysis and design, network management and cybersecurity, medical and personal devices and IT record interoperability and security, database and data and big data analytics, systems project portfolio and lifecycle management, and artificial intelligence and machine learning, and the list goes on and on. But these are fundamental tools that we need in order to sit at the table with our colleagues who are at the C-suite, the CEO, CIO, CMIO, the ministries of health. These are all today's contemporary issues and topics that we need to be able to speak to. Next slide. Ricardo and I have put together over the past several years a whole suite of courses and courseware for certificates. We're glad to share this information with you. We're glad to help you develop these programs and trainings in other languages and other frameworks. Next slide. We go into all the latest areas of artificial intelligence, software and systems engineering, security, cybersecurity, and management. The point is that you don't have to start. You can build on the work we've already done. You are all part of a large global team, and this is something that we have to do as a team effort. Next slide. We probably need new enhancements to our clinical engineering certification programs that identify unique skill sets properly and effectively. Not everybody is going to develop all of these skills. Not everybody has the interest or aptitude, and we need specialists to play the different bases, such as lab or imaging, and they may or may not all have the same skills, but we do have to have a way of defining and properly certifying these skills and capabilities. And next slide. Ricardo and I and everyone else on this webinar are absolutely willing and interested in speaking with you, supporting you. And now we're going to turn the session over to the next slide and open the floor for questions and answers. We have a really great panel, more than happy to answer your questions. We've been answering a lot of them as the system has unfolded and the presentations have unfolded. So we have a question here. How is digital health applied to help populations in poverty nowadays? What kind of actions or solutions are being developed? Anyone want to speak to that?
I actually will have a short comment, Elliot. I shortened it for time, but I did have an entire cost-benefit section in my presentation, which just wouldn't fit within the time. Here's something that's very important to note. If we enjoy efficiency improvements through our investments in digital health, it is an executive decision what to do with those. In Canada, in the United States, in the European countries, we want to divest our efficiency improvements. We want to bend the cost curve. We're spending a lot on healthcare. We want to get the same amount of healthcare, but we need to be able to bend the cost curve. It's the complete reverse of that in a low and middle income setting. Most of the work that I do is in low resource settings. We don't have enough of anything. We don't have enough medicines, nurses, machines, surgical suites. We don't have enough of anything. And when we implement digital health and enjoy the efficiency improvement, we want to invest that efficiency improvement. With the resources we have to bring to bear, what we want to optimize is how much health can we get per dollar? How can we optimize the DALYs per dollar? So in my view, in a low resource environment, in a poor country, it is actually a moral issue to be able to enjoy these efficiency improvements. It has the effect of creating capacity. So I wouldn't say that digital health is something that you don't invest in a low resource environment. I think it is even more important. It's got a moral imperative behind it. I will say this. If you can't make that business case to a Minister of Health, and it's very much the work that I do now, if you can't make that business case that what the impact will be of digital health, then they know exactly the benefits they're going to get from drilling another water well or hiring some more nurses. So if you can't make that, we actually shouldn't be investing in digital health if we're not going to make sure that we do what we need to do to enjoy those benefits. They are there to be had.
Thank you, Derek. I would also point out that the use of apps, smartphones, and the pervasive nature of cellular communication has opened up digital healthcare to many populations that didn't have access or don't have access because of distance and cost. And so we are actually in a sort of a perfect storm, but if there's a silver lining in the coronavirus crisis, we are learning new methods of telehealth, and we're providing new methods of telehealth at a distance, care at a distance, that is going to make access to populations, and don't define populations of poverty only in other parts of the world. In the US, in Canada, we have many rural populations that are nowhere near physicians or hospitals. And these are tremendous tools that are making healthcare available to more and more people at affordable costs without a lot of infrastructure build out. Anyone else want to comment on this? I'll also say it relates to the next question. It says at primary healthcare organizations, e-health demonstrates quality and sustainability impact. You know, what kind of evidence or documents can we provide? I know WHO has made this a major emphasis of the current WHO Congress in terms of providing digital health and enhancing and expanding the application of digital health to all persons. Ricardo,
and their new department as well.
That's correct. Ricardo, do you want to make some comments?
Sure. So echoing what Derek was saying and what you were saying, Elliot, the pervasive nature of digital technology, there's a cell phone in everybody's pocket all around the world. The problem is how to better use that technology to serve the people, to provide the health intervention, like Derek was saying also in his presentation. So it's not a lack of technology what we have right now. It's a lack of innovative approaches to use this technology to better serve the population. And there is where engineers have an upper hand. Here is where we all need to come together and learn best practices from around the world to improve the outcomes by using what we have available.
And to talk to primary healthcare, Kaiser Permanente has identified telehealth as more than half of its healthcare. They cover over 10 million Americans. We're also working with the Ministry of Health and others in India, where by the end of this week, there should be a release of an entire new and dramatic digital healthcare framework for the entire country. And we know, in working closely with our colleagues, with Dean David and colleagues in China, that digital health is a fundamental part of all the clinical engineering practice in China, and has been for the past decade or more. It was never assumed it was anything but a clinical engineering discipline. Dr. David, I know you're with us. Do you care to comment on that at all? You may be on mute, but I can tell you in my my visits.
Thank you,
Yes,
Elliot.
please.
You're absolutely right. I have a couple observations that would be helpful. One is that the differentiation between engineering, informatics, and, like Derek said, the new field of evangelists in the area of health information system is very blurred, especially when you leave the Western medicine and you move away to low and middle income countries. And it's important, therefore, to highlight that the competencies and the lack of definition between the fields is such that providing tremendous opportunities for us, for clinical engineers, to gain and show the value as we come to the table with understanding of systems. And Elliot, you are big on system engineering. That's where we need to go with this. So I would like to suggest that in China, that's one of the major evolution, is looking at healthcare and seeing system engineering coming in as compared to a cottage industry that was there before. Thank you.
And during our visit with the Hangzhou Children's Hospital some 4 or 5 years ago, their clinical engineering department wrote their entire electronic medical record system for the hospital. Their department develops and supports all of the apps for patients to care for their children, to do registration, get lab results, to schedule appointments. And it is, there's no question, it was never a question that was part of their obligation and requirement, in addition to the CAT scan and the cath labs and all of the other technologies that they support. And Eric, you might, comment on the data behind the scenes infrastructure, the infrastructure to manage the data. It really doesn't matter whether you're a Minister of Health of Turkey or China or India. The same fundamental issues of how to get data, collate data, get quality data, and use the data to make decisions applies anywhere on the planet.
Yeah, absolutely. And Derek did a great job distilling so much wonderful content about the infrastructure nature of that. But tools like FHIR, we're super excited about, but in many ways, they amplify the need for aggregating and normalizing and cleaning up the data. We view dirty data flowing through pipes today like that. We think FHIR makes the pipes much bigger, pushes more data, more pressure, but it doesn't fundamentally solve the issues of cleaning it up. So that's a universal problem, as you point out.
And it's a fundamental problem or challenge of informatics, which Derek referred to. And in the US, we're struggling all around the globe with COVID-19 diagnostics. It is so hard to pick out the data from the noise. It's so hard for us to determine emergent coronavirus patients versus patients who've had 20 tests in the past for a variety of reasons, all of which are negative, or have had repeated positive tests, all of which contaminate the flow. It's very, very hard today, and we need to get better at it. Clearly, this pandemic has made it exquisitely, painfully clear that if we can't get down to the local data and understand what is happening in the town, village, city, state, nation, we can't take action.
Yeah, I would just quickly add, Elliot, that while there's certainly remain challenges, I think never in human history has there been so much collaboration around the data that is being exchanged, and the rate at which collaboration is happening across the globe by sharing data, by interoperability, by democratizing best practices outcomes is very exciting. And I think we're only going to see that continue to accelerate in a post-COVID world.
I also think that there's an important role that's being played by WHO at this juncture. They really have doubled down on digital health as their way to close the no-do gap, to increase guideline adherence. And in many of the low and middle income countries, it's more of a greenfield. And so some of the challenges around the very, well-funded proliferation of different systems and different solutions, we don't find that necessarily in all of these contexts. And there is an opportunity to have these organizations, these ministries of health, learn from what's worked and go straight to the end game. I think that there are leapfrogging opportunities for some of our LMIC partners, and how great is that?
Absolutely. And it's a good time for us to close. This is a beginning. We plan to have another webinar on telehealth, probably a different webinar on artificial intelligence and expert systems and machine learning. There's so much going on in this field, and there's so many opportunities for clinical engineers. We've lost Axel because he had another appointment that he had to go to. Any biggest thought you want to leave, Eric, with this group? And then I'll come to Derek and then to Ricardo.
No, just thanks for the opportunity. We're all in this together, and it's just great to be part of a community that cares deeply about improving the quality and the outcomes of healthcare. So,
absolutely. Thank you, Eric. Derek?
That this is important work, and that we engineers have a very important role to play in this. This is really going to matter. A bit of a call to arms, Elliot.
Absolutely. Ricardo.
Yeah, I will echo what everybody else says. I know that amongst the participants, there are some regulatory bodies. So now there's a new opportunity because the technology is out there and the clinical engineers and the people in the field are the ones that are going to validate the use of that technology. And post facto accreditation now it becomes a new word in the toolbox. How do we assess for the best technology to put into our pipeline? So it's an interesting world out there.
It is an interesting world, and you know, I really have to thank all of you for your participation, and IFMBE CED for hosting this session. I want to close with a real important statement, which is this is a team sport, it's a global sport. This is important to us because we all love our children, we all love our families, we all love our nations, we all have an obligation and commitment to make things better. I do have to say that although this happens to be a panel of men, this is very much a gender-neutral sport. Many of the executives and leaders in this field that I work with are women, and they just don't happen to be on this panel today. But we have an enormous global repository of skill across all genders, all nations, and we invite everybody to participate and give us feedback, give us guidance, participate in leadership. And with that, I'd like to call this session to a close, and you'll see some of those women in this picture, in fact, in the front from our conference in Rome. We have so much work to do, and if you picture yourself, as I do, as a Swiss Army knife, with this digital medicine era, think about that really thick Swiss Army knife with about 200 different blades. We have a lot of different tools now to pack into our toolbox. Thank you all. Have a great day, morning, evening, wherever you are in the world, and we look forward to working with you all again in our next presentations.
Thanks all. Stay well, everybody.
Everybody stay safe.